procedures to ensure that we have the right instrumentation available. To John Muir's credit, they've done a phenomenal job because they have almost everything Shula. And I say that because Shula, I've been in the industry, as I said, for almost 20 years, is the only company that specializes in hardware removal instrumentation. So whether it's Medtronic, Stryker, Globus, DePuy, Zimmer Biomed, doesn't matter. They're not biased to any company at all. They focus on taking everything out. That's the focus of the company. They do not manufacture implants. That's not where their bread and butter is. It's just, hey, whatever you have coming in, we're going to provide you the most capability to get it out. My experience, my personal experience has been, we have gotten everything out that I've been involved with except for one case. It wasn't because we didn't have the right attachment. It's because it was a 30-year-old femoral IM nail, and that thing just was not budging. It was not going to leave the canal. And I'll have some videos for you today too to kind of show you. I think it's critical that no matter what part we play in the healthcare system, we understand how the stuff is used because it gives us a better idea. Really quick, Pete, I'm sorry, how much time do I have to make sure I'm sticking to it?
Let's stop at 7.
At 7, okay. So we have, okay, and I'll stop before that for questions as well. So my intention today is to go over the new spine system we have here in-house. This is a new offering to John Muir Health. And then we also have some other systems here, and I'll address those questions as well, just to make sure you have some familiarity with what you have available when you get that call from upstairs. What do we have down here? This is the spine system. One thing that I want you to be aware of is, most trays, as you know, are open like this. And this one has been designed that you can still do that. And you can still flip the lid off here, and that's okay. But what you're going to find is once you do it, you're not going to be able to really see what's in this tray. And the reason why, because you want to rotate it 90 degrees in order to see the contents of the tray. So it's stadium seating presentation. And the reason for this is we just found it's a lot easier for the surgeons and the surge tech to be able to identify what screw drive they might need. To give you an idea, there's almost 200 different screwdrivers out in the market for spinal screws. It's ridiculous, but it is what it is. So UCSF, Stanford, the big academic centers typically will get the community surgeons. John Muir's a very busy institution too, as you know. A lot of spine surgeons doing surgery here, whether it's neurospine or orthospine, and they'll have patients come in from other surgeons, from other areas, and they already have a construct in. Maybe they have an L3, L4, L5, S1 screw fixation, and there's no implant record to show what's in there. So then, their first concern is, well, how am I going to get the stuff out in order to do the procedure that I'm trying to do? And sometimes it's an adjacent level. They want to go up, and they have to do a full revision. They got to remove everything out. Most often, implant or explantation is not because the patient wants it out. Most often it's because the surgeon needs to do something else. If it was that, if it was the prior, then we'd be on a big uprising. So all these different drive types in here, some are very basic: Torx, X, female, male, and then down the very bottom you kind of see very specific drive types. This is your Strykers, your DePuys, your Medtronics. They're very specific as to what type of drive they decided they wanted to use and run with in order to insert their screw. And just a quick recap, who here is familiar with spinal screws? Anybody who maybe see, other than seeing them and watching them, that's about it. I think it's worth showing you just a quick picture of what I'm talking about. So this is an L5 S1 screw fixation. So you have 2 screws in L5, which is on your left side, and then you have a rod in between that connects down to S1. I'm pretty sure it's L5S. Yeah, it's L5S1. So the 2 screws here, 2 screws here. So what they do is they take these pedicle screws, they put them down the pedicle in this orientation. So if you have an axial view, you see 2 screws coming down, so L5 and then S1, and then that segment, they're going to fuse that segment. And typically it's because, yes? S? For sacral. So S stands for sacral, so your spine is made up of your cervical region, your thoracic region, your lumbar region, your sacral region, and your ilium, okay? Or coccyx, actually. So and each segment is identified by a number.
Yeah,
so you have, yeah. So for this particular example, a lot of the degenerative cases that happen are L5S1 related. So whether it's degen, whether it's trauma, whatever the cause might be, there is something that's happened that led the patient to have surgery. Most often, that patients have failed conservative treatment, injections, physical therapy, exercise regimens, etc. And they finally get to the point where, this pain is so unbearable, I get tingling in my legs, surgeon says, what, I can address that portion for the most part. Not sure about your back pain, but I think they'll be pleased with the results, and that's what patients do. They have a fusion. This particular case, this patient had this surgery back in 2000. So you can imagine, and this is just a recent case we did here in the Bay Area, and another facility that's looking to acquire this system as well. So one thing that Shula has available, and I implore you to use it, and the surgical team, I'm telling them all the time, we have something we call an X-ray search engine. So once you send the images to me, of course HIPAA compliant, no patient data, I then send it off to our expert search panel. The expert search panel consists of product managers of different companies, surgeons, surge techs, representatives, and they look at the information. I think this is this manufacturer, whatever. So that way we can identify potentially what's in the patient, and then we can go, you know what, it's going to be drive 53, and then that way they go, they pull it, it works, fantastic. Everyone's moving on with the procedure. Some cases, in this particular one, we thought we knew what it was. We get in there, come to find out, these caps right here, and just a quick breakdown on this. A pedicle screw is one item that goes into the pedicle, and then you have a rod that goes into the saddle, and then you have a set screw that goes on top, and you final torque that set screw. So it's one lock mechanism. So all 4 screws are interconnected. And then they'll lay down biological components, whether it's from the patient, what you call autograft, or it's allograft, or maybe it's synthetic. There's so many different concoctions that are out there, and surgeon preferences. But once they put it in there, it's a race to fusion. And if you get fusion before the hardware fails, you have the success, given that the patient's no longer complaining or their symptoms have improved, the pain and function, etc. So in that situation, it's a success. And obviously the patient had this in 2000, so they're doing well, right? Well, now it's 2018. They need to have this out because they need to extend the construct. And so they're doing, and that means they have to go up to, I don't remember if it was L4 or L3, but they have to do a longer fusion now. So you have to get everything out. So we go in there and remove everything. Come to find out, these set screws don't come off. These screws back in the day when they were designed were never intended to come back off. Once they go in, that's it. So what the surgeon ended up having to do is he had to cut the rod, actually within the patient, as you can imagine, so very carefully, did a full exposure midline, open the patient, cut the rod, and then none of these drivers were working to engage these screws. So what he ended up using was this, and I'll show you this tool here in a minute, this helicopter socket. You can see this helicopter socket right here. Now it looks just like a tire iron, as if you're changing out your spare tire on the road. And what this is intended to do is it goes over the screw, captures the rod, and then backs it out. And everybody was happy, we got everything out, and moved on with the procedure. So the intention of Shula, kind of going back to where I started, is giving the surgeons, SPD, surgical team, and the patients knowing that they're going to have the most capability to get stuff out to move on with the procedure. Because the procedure is not to get the stuff out. The procedure is to actually do an additional fusion. We have to get the stuff out first in order to do it. So these are different drive options. You only have lumbar drivers here currently. It was decided by John Muir at this point to hold off on doing the cervical tray. There's actually 3 trays in total, but you have 2. And it was based off of feedback from the surgeons and from the surgical team upstairs that really that's kind of our pain point that we need to address. So it makes complete sense. So you have, I think approximately, it's about 60 some odd drivers within your lumbar offering. Each one has a number. As you can see, I'm going to bring it around here so you can see the different numbers are on there. And then there's some extras areas over here too. Those are intended, they're not currently filled. You're going to have pictures of all this stuff, excuse me, and, for archiving and confirming. But those are intended in the event an extra driver comes out. If we identify a screw like we did a couple weeks ago, we can design that drive type and then put it in the tray. So we're always trying to stay up with what we identify or new screws that come out. But if this comes down, all these should be in here. They're all the same working length, 4 inches in total. There's an extension that we can put on, and there's, this is a 6.0 millimeter cruciform, and there's a lot number, and then there's this item number, SDR754. Every single item is laser etched this way. So, and then, not understanding all that, you go here, 54. Okay, well, 54 goes here. There's a little detent. You press it down in there and it actually stays. What I will share with you is if you try to put the lid back on, if one of these is just riding up just a little bit, you're not going to be able to get this thing back on here. As you can see, I'm having an issue. Now it slipped back down, luckily. But if it's riding up, it won't go back on. So just make sure everything is fully seated. Everything should be flush. Everything should be flush in the tray, so you shouldn't have any issues seating that lid back on there, okay? So this is the driver, and then the auxiliary tray. So when they call down and they say, we need Shula, or we need an extraction system, the first question you're gonna wanna ask is, well, what region in the body you're working? If it's spine, you know it's this. This is Shula spine. I worked with Pete and Susie a few months ago, and Maggie, about making sure everything was called Shula and then whatever it's designated to do. So when you're thinking removal, think Shula, and it's going to be, because right now you have Shula broken strip screw system here. You have Shula Windquist, which I am nail. You have Shula hip. You have Shula maxi, large frac screws. I think those are, I think that's it. That's here currently. And now you have Shula spine. So if they call down, they're frantic, and most often they are, right? They're urgent, they want to get moving, and they haven't planned ahead of time thinking they might need something. Ask them which region of the spine. They say Shula spine. Okay, Shula spine. It's going to be two sets: tray 1 of 2 and tray 2 of 2. This is it, or case. This is case 2 of 2. This is case 1 of 2. So you know there's 2 trays in total. And then this is your auxiliary tray. You can't use the drivers unless you have the appropriate attachments. And this has your inline handle. This has your T-handle. Surgeon preference. Has different extensions here. So depending on whether they want a 4, 6, 8, or 12-inch extension. If they go, sometimes they go really deep into the wound. If it's a really big patient, they go on posterior. Maybe they go on lateral at the cubitus position. So there's different options there. Then you have needle nose pliers, rod holder, you have different wrenches. And then the beauty, as I said, this is the backup to the backup. In the event they have to cut something, you just load this on. It's a breaker bar. This is also in your, you'll recognize this. This is in your broken strip screw system also. You have 2 or 3 of them here. And it just attaches this way. And then you have this socket, different sizes. This will go up to the larger size rod that's on the market. Intermediate, and this is more for cervical application. And then this just pops right on here. And then they're ready to go. And it's all reverse fashion. So as you can imagine, this gives them a lot more torque and ability to get it out versus the little tiny T-handle, which can be challenging. So that's why this is built in. So this is a beauty. Nothing in this tray should be missing at any time. And same thing for this, with the exception of the extra areas. I'm going to stop there. I keep going, so my apologies. I love to talk. Questions, please.
If there's something missing out of any of those trays, it cannot be used?
It really depends. That's a great question. My recommendation is, if something is missing, do you ever do photo documentation here, or how do you track it? I would photo document and still wrap it and put it up. Because if you're missing one of these extensions, you can still use the tray because you have other extensions to count on. There is redundancy within the tray, with the exception of the different drive types. There's only one of each drive. And the surgical team, I know this is a challenge, and this is why we do what we're doing today. The surge techs really need to understand that something's not working properly, because these will wear down over time, right? Your standard T25s, your T27s, your T30s, your Hex 3035s, etc. Because you have to keep in mind, once they put those pedicle screws in, and then they put that drive in, and they're releasing it, there was a at least 90-inch torque pound tolerance that was required to get that set screw to bite in. And so in order to get it to release, there's a lot of torque going back. So there's a lot of metal on metal, and over time, just like the maxis we had about 2 weeks ago, or 2 months ago, whoever was here, but it's not working. Well, because it's stripped. It's going to strip, it's going to wear down over time. So we've asked the surge techs and the circulators, just flag it please, so when it comes downstairs, because frankly, I mean, ideally what you're going to want to do is inspect and make sure everything looks good to the eye, but your eye's not going to catch everything, no matter how big you are. And I'll take that challenge anytime, because you look at, I think a perfect example would be a hex. You look at that, right? I mean, it's 6 sides. I mean, how are you going to catch it if it's just worn down in one particular area? It's not going to grab. So that is the recommendation, even if one of those are missing, I would still put it up, unless Pete feels otherwise. But that would be
Our
my
policy
recommendation.
is to assemble trays even if missing.
If it's missing, okay. But definitely identify what's missing. And then what I am recommending facilities to do is have the standard sizes that are used most frequently on on the back shelf, just in case. So something goes, or we know it's already starting to strip, pull it, refill it, and then order another one so they always have it. These are about a couple $100 each, and they are intended to be reusable, so it's not a huge expense. But you got to be on the ready, and that's the whole idea of a Shula is to make sure you have capability. Most often, facilities will buy multiple sets. That way, they don't have that issue. And that's what John Muir has done, and probably that's what we'll end up doing here eventually once the surgeons know that this is in circulation. One other thing that was asked at Stanford, because Stanford just upgraded with the system too. What happens if the general ortho surgeons want to use it? Question will come up. My stance is no, but it's, I'm not working here. I'm not taking that call. You have the Maxi systems here. The Maxi systems, you have 3 of them, and those are intended for general orthopedics. And the majority of what they're going to come across is what's in that tray. Yes, there's a lot. I mean, it's the neatest, newest thing, right? Shiny, everything else. But these types of drives are very unique to spine. So I would encourage them. Oh yeah, okay, and then just ship up the Maxi. And if that doesn't work, then the secondary option would be the broken strip screw removal system, the Shula broken strip, because that will capture any screw, whether it's broken, stripped, or if it just won't budge because it's cold welded. Those work fantastic to grab and just pull out. And I've been in multiple cases to provide that testimony. Any other questions before I go on to hands-on? So Pete asked me to have hands-on, which I have here. And then I also have some videos and case studies. What would you like to see first? Case studies? Hands-on?
Hands-on.
Hands-on. Come on up, please. Come on, let's go. You said hands-on. Let's go.
I was falling asleep, that's why I can't.
So everyone's seen kind of this and your broken strip screws that you have here. So this is intended to get any broken strip screw out. My favorite is to use the broken. You can use the stripped, which look like this. And the intention of these is to either grab, in the Sawbone model we have strip screws here. And so this is great if you have a strip screw or if we don't have the right drive type. And this can be used also for, well, back up. For spine, it's hard to use these. And John Muir's looking at another system we have with a longer, pardon me, let's take a look to see if I have it here. And let's lift it out. Oh, there it is. A longer extractor, which looks like this. See the difference? So here's the challenge with this. From a spine surgeon perspective, when they're going posterior, going down the barrel, they don't have good visibility. Not optimal, and most likely they're not going to use it. This though, down the barrel, fantastic. So this is what we're looking to do for spine service. So it's a consideration, but most often it's going to be passed up on. So the idea though is for a strip screw, it's going to reverse thread, it's going to bite into the screw and it's going to back it out. And then the broken screw is going to go over the screw, whether it's the shaft or the head, and it'll grab it and back it out. So I'm going to do a quick demo here. A lot of these in the past would have to core over the entire length of the screw. They'd have to template it, have to get an idea how long they had to traverse down into the bone. This design is a simple stab and grab. It tapers, so at the distal end it's wider, and then it tapers down as it travels up. So it just grabs it and pulls it right out. I'll do it first and then you can do it. The key to this though is it's always reverse, reverse. You never go forward. And then it's always constant pressure, not overbearing, but just enough pressure to make sure you kind of hold it steady. Low RPM, so I'm not depressing the button all the way. And then high torque. And here's the key though, you got to be patient in order to get the screws out. Now the surgeons here are very familiar with this system. They've used it before. Dr. Sufal, Dr. Fulkerson, etc., Dr. Chronic. And then once it grabs the screw, it literally just pulls it out just like that. So I can't tell you how many times this has been helpful at home, for projects at home. I just pull out my demo kit and go. So that's it. These are intended to be single use. Now the question I get most often is, what can I use it multiple times for that one patient? If the team can safely get this tip off, I think that sounds reasonable. These are sharp, but if you can't, dispose of it, my recommendation is they put it next to the tray. However many they use, usually it's about 1 to 3 per case. Put it there. Upon final count with the circulator, do a final count. That way they can charge the patient how many tips were used. Then it goes downstairs. It's going to be missing those tips. Right now, currently, SPD, you're handling kind of the reorder process, but I think we need to revise that, or Pete and I are discussing it and see what we need to do there. So that's how it works. Put it back in. So I'm going to give you a brand new one because it's been used multiple times. Oh, it's easy. Trust me. So the key is don't go all the way, right? Just slow and steady. Okay. Here you are. So you get the new one. What's your name? Jillian. Kevin. There. Yep. And make sure you hold it firm and steady. Yep. Good downward pressure.
Oh God, I am no.
Are you really nervous about a hand?
Remember, good pressure. It's not going to bite you. You got to get some good pressure on that
Watch
tip.
out though,
Push
when
it
you
down.
turn, it might turn you.
There you go. Good. That's good. Good
I think
RPM.
it's heavier than.
Yeah, you're fine. Keep going. Just slow it down a little bit. There you go. You can pick up the speed just a little bit. I can see Jillian's are starting to come out a lot faster now because this is a brand new tip too. And you can pick it up now if you like. You'll feel it kind of go up against your hand. Let it travel now up towards the ceiling.
Is it coming up?
Yep.
I can't see it. Am I supposed to
Maybe a
feel
little more
something?
pressure here.
Oh.
There we go.
Oh,
You just
there.
need a little more pressure. See? That's all it is.
That's it.
And there you go. Just
You're
expanded your
awesome.
first screw. Nice job. Congrats.
Ha!
You are now a
You're ready to go. So I was in a case recently where there's an ortho fellow, and we used 9 different broken strip screw extractors because he was just going too fast. He wasn't giving it time. And it was charring, turning black. You could smell the smoke. They're pretty wild. But once the attending came in, he said, no, slow and steady. And then that's the key. Good pressure, slow and steady. That screw will come out. But you got to keep in mind when the surgeon's moving, they're moving fast, right? I want to go. And so we have to remind them, if you want it to work effectively and work well, you got to take the time and let it do its thing. So that's the key there. This is open for anybody who wants to come up. Just the last couple of things I have up here. Just a few more minutes.
How is disassembly in decon when the stuff comes down and it's all together? How is that? Is it pretty easy?
Actually, yeah, it's very easy. There's really the only disassembly that you have here at John Muir that you have to worry about when it comes to Shula would be your Mueller hip extractor.
Okay.
That's the only thing that's disassembled at this point in time that we're aware of. Everything else, yeah, you're good to go. Great question. Thank you very much. Yes?
Can we talk about identifying, how to identify whether it's the conical or the external extractors? How to
Absolutely.
identify it if they've been used in the OR, because I know they have been sent down used, and
Yep.
because they're one-time use.
That's a great question, Pete. Thank you. So I'm going to pass these around. And the way you're going to be able to see, and that's been an ongoing issue here that we've been dealing with, and Pete's been very helpful, and Susie, you're going to be able to see the difference between what's been used before and what has not been used. So I'm going to pass around these two. One's a little more shinier. Just look at the tip. There are some metal shavings, so it kind of gives it away, but you're going to see the discoloration of the tip versus this one. It does not look discolored at all.
Do not feel bad about tossing these. They've been charged to the patient. And
See the difference? Yeah,
if it's
definitely
used
see the
on a
difference.
second
One's
patient, it
machine,
may
one's
not grip
Yep.
this.
When it's not, has been used.
And even the discoloration on that, you'll see that as well. That's another indication it's been used. So if it's been, there's 4 of each size. So dispose of it so it gets reordered. Because here's the challenge. If it goes back upstairs, as we know, and they use it and it doesn't work, then they get frustrated, right? And then you're hearing and you're getting it. And I'm getting it too. Trust me, I get the phone calls as well. So make sure that they're disposing. If they're not, just do your due diligence on the broken strip screws. Same thing. For this tip here, there's 4 legs on it that bite. And when they've been repeatedly used, one of those legs will break off. So there's only 3 or maybe 2. Yeah, there's those 4 little legs, exactly, the tips.
I've seen them like that, but they may not be broken off. They'll just be like kind of bent a little.
Yeah, if it looks bent or if it looks suspicious, I would
You
just,
may also see a brown or bluish color around the outside if it's been used as well.
yeah,
Yeah.
Yep.
Meaning it got overheated.
yeah, absolutely. No, that was great. Thank you. Good point on that one. Okay, so I'm going to just wrap up with a couple case studies here. I showed you the other one we just did recently on Christmas Eve. That was a fun night. And that's what the screws look like. So you can see those caps were never intended to come off.
Just give me that damn wood screw there, pal. Put it right back together.
And then another one we did recently was with the broken strip screws. Now that was with this system here. We don't currently have here eventually, but this is also with the same spine surgeon. What was unique about this one is he did it down a sextant tube. So didn't have full exposure, very minimally invasive. Really neat procedure, but he was able to go down and he opted to go with the broken extractor. And what had happened in this particular case is if you see here, this is the L5 screw right here. You see the head right there? This is a professional soccer player who had fusion years ago, well, actually 3 years ago, I say. So not years, but. And the L5 screws on both sides had sheared off the shaft. And he had to go and do a full revision. So in order to get the screws out, no drive's gonna work. You gotta use a broken strip extractor. So what you see here, it's over the screw, this is a broken extractor, which is very similar to this. It's actually one of these. It's a bigger size though. And he got it over, put it to power, slow, steady, good pressure, and he just pulled it right out, both sides. So great success, but what was really cool though is you can see the sextant tube up top. You can see where it's traversing down. So he doesn't have great visibility, but he's well trained. He did a fantastic job, and it was just a neat procedure to be because, you know, they're shaking hands, clapping on the back table, and they move on with the procedure. That's the most important thing. That's all I have for today. Any other questions? I love it. Thank you very much. I appreciate your time. And any questions, please let me know. My pleasure. Thank you. Donuts are in there too if you haven't got them.